In this section, we're going to talk about the clinical presentation and the management of lung cancer. So the thing about lung cancer, for many patients who are developing a lung cancer, they have no symptoms. So this is a chest x-ray, and in this box you can see a very small nodule. Now that nodule is not going to make the patient short of breath. It's not going to cause chest pain. It's not going to be close to an airway and cause coughing up blood or hemoptysis. So this can be clinically silent for years. It may be discovered if a chest x-ray is obtained for another reason. Unfortunately, we often meet patients with advanced disease that are not surgically curable. So, for example, this is a patient that presented with cough, dyspnea, or the feeling of shortness of breath, and the coughing of blood of hemoptysis. And you can see by the time he presents now, he has involvement of most of the left lung, and that's what made him be short of breath and present to a physician. This is the CT scan of the same patient. So this is a section here right through the middle of the chest. This is the sternum. These are the ribs. And I've changed the contrast on the CAT scan so you don't see a lot of the normal lung, but you can see the ascending and descending aorta here. And this corresponds to the lung cancer that's causing the opacification on the chest x-ray. Now, with this patient, we went ahead and did a bronchoscopy, which is a thin, flexible scope that you can see directly into the airways, and this is what we found. So this is the airway. This is the left main stem airway. Here's the opening to the left lower lobe, which all looks fine. But then you can see there's a tumor here completely blocking the takeoff to the left upper lobe. In fact, the tumor then went beyond this and was all that area. So this is the problem. We have patients who don't have symptoms when it's early and it might be surgically curable, and don't present until it's late and is already too big to take out or has widely metastasized. Now, when patients do present with symptoms, these are the classic ones. Cough, again, it might be irritating an airway and causing triggering of the cough receptors. Weight loss from advanced cancer. Dyspnea or shortness of breath if it's involving a significant portion of the lung. Chest pain if it's involving the chest wall. And then hemoptysis if it's in the airway. Bone pain, and we'll show an x-ray of a bone where it's metastasized a bone, and then we'll show specifically how lung cancer can cause hoarseness. Now, as I said, unfortunately, most patients with lung cancer present with advanced stages. And I'll show you several different syndromes that show these advanced stages. The first is something called SVC syndrome, for superior vena cava syndrome. Now, this is a CT scan that I have here, and I've changed the contrast so you don't see the lungs well. But I've specifically was given intravenous contrast material that lights up the ascending and descending aorta. Now, this little flat white line is where the superior vena cava, and you can see that it's compressed by tumor this way and by the lymph nodes that's involved with tumor that way. So it's really put a cinch right on the superior vena cava. That makes it very difficult for blood to drain from the upper part of the body. So what you'll see in patients is elevated jugular venous pressure because the jugular veins to drain into that SVC. You'll see prominent veins on the chest because blood has got to drain down from the upper extremities, the face and the neck, but it can't get through the SVC, so it dilates these superficial veins to hope to find another way to get back to the right atrium. Because there's increased pressure, then you have fluid that moves out and causes edema of the face. This is a picture of a patient with the SVC syndrome, and you can see his face is somewhat puffy. And then after he's treated with radiation and chemo, you can see that puffiness has gone away because it's opened up that compression of the SVC. Another manifestation of advanced cancer is something called Horner syndrome. So in this chest x-ray, you can see that the right apex has this opacification, which turned out to be a lung cancer. And then you have this picture of this gentleman, and you can see that he has ptosis and meiosis. Ptosis is this drooping of the eyelid, and meiosis is that his pupil is smaller. Now, this is because this tumor, here it is on the x-ray, and here's just a cartoon of it. You can see if the tumor right up here in the apex of the lung is compressing on the sympathetic chain here. And that sympathetic chain supplies the dilator muscles of the pupil. So in a sympathetic outburst, the fight or flight mode, you would want to see well, so you would want to dilate the pupil, but this pupil can't dilate. It also, the sympathetic things also controls part of the lid. You want your eyes open if you needed fight or flight, but this patient can't do it, so has a droopy eyelid or ptosis. Now, the sympathetic chain also controls sweating. Now, this, if a person's not sweating, you wouldn't notice this, but if they were sweating a little bit and you took your hand and you moved it across their forehead, you would find that the involved side is dry and the normal side has a normal amount of sweat on the forehead. So ptosis, meiosis, and something called anhidrosis, meaning the lack of sweat on that side. Now, another clinical presentation of lung cancer is hoarseness or a change in voice. Now, this is a cartoon that shows the course of the recurrent laryngeal nerves that supply the vocal cords. See, the right recurrent laryngeal nerve just goes a little bit around the subclavian artery, but the left recurrent laryngeal nerve goes all the way around the arch of the aorta. Now, this means that any cancer in this area that causes enlarged lymph nodes in this area can compress on that left recurrent laryngeal nerve and make that left vocal cord not move well. So in this video, this is a laryngoscope. So an ENT physician is now looking down the airways, and you can see now to the vocal cords that that left vocal cord does not move well. And so that will change the voice pattern. In addition, advanced lung cancer can cause bone pain by bone metastases. So this is an x-ray of a femur, and you can see there's a punched out area that tumor has gone to. In addition, because this has thinned the cortex of the bone, when weight was applied, such as walking, there was a fracture there. So sometimes a fracture might be the first manifestation of advanced lung cancer. Other times the bones can just hurt before a fracture can occur, and so patients may just present with bony pain in different parts of the body. In addition, lung cancer can spread to the pleural. You can see this lumpy, bumpy area on this CAT scan. So again, this is a CT scan halfway through the chest, ascending, descending aorta, ribs and sternum, and there's a large pleural effusion throughout here. And that is due to a lung cancer that has metastasized directly to the pleura, and it's these metastases that are churning out and making this additional pleural fluid, plus blocking the removal of this pleural fluid. So pleural fluid being made in excess and not being drained. In addition, if there's tumor mets to the pericardium, you can have pericardial effusion. So this time the CAT scan is, rather than a cross section, it's going this way. And you can say, here's the heart here, but it's encased, and here's the pericardium, and the heart is encased in all this pericardial fluid. Now this is an echocardiogram of the same phenomenon. So this is an ultrasound of the heart. This is starting at the chest wall. Here's the pericardium here, and here's the heart. And here, all of this is pericardial fluid. Now, looking at this, you can see what the problem is with a pericardial effusion. In addition to being a sign of advanced lung cancer, this is the right ventricle. It looks like it's almost being stepped on. And that's because the pressure in here is so high, it's not allowing for right ventricular filling. So this patient might present with hypotension, because if blood can't fill the right ventricle, it can't get around to the left ventricle, and you'll have a drop in cardiac output and blood pressure. Another presentation of lung cancer can be something called paraneoplastic syndromes. So these are a set of signs and symptoms caused by the cancer, either due to hormones or cytokines excreted by the tumor, or by an immune response by the body against the tumor. So in this case, even small surgically curable tumors can cause paraneoplastic syndrome. So this does not necessarily mean this is advanced lung cancer, even though the patient is having systemic manifestations of it. Now, tumors can excrete hormones. They essentially go back to a very rudimentary state. They forget they were originally lung, and they start making hormones as if they were a different gland. So tumors can make parathyroid-related protein. So the parathyroid hormone controls calcium. So when a tumor makes this, it's essentially saying to the body, I think the calcium is too low, even though the calcium might be normal, and that increases serum calcium. A tumor can make antidiuretic hormone. Now, antidiuretic hormone makes the kidney hold on to water. And so if the tumor is making excess of this, then it essentially makes the blood more watery, and that can drop the serum sodium and cause hyponatremia. Now, another paraneoplastic syndrome is where a tumor either makes excess cortisol or the tumor makes excess ACTH, which causes the adrenals to produce excess cortisol. Now, you'll learn about the properties of cortisol later, but it essentially causes weight gain, can make the serum glucose go up, can make patients weak and more prone to infection. Now, those are the hormonal paraneoplastic syndromes. There's also some inflammatory paraneoplastic syndromes that actually can cause neuropathy and cerebellar degeneration, and then the person will have problems with balance. So they might present with a neurological problem that can resolve once the lung cancer is taken care of. Patients with cancer of many different kinds, not just lung cancer, generally have a hypercoagulable state. And so they might present with a clot or thromboembolic disease. Nails can have a particular phenomenon with lung cancer, and that's the process called clubbing, in which there is a widening of the nail bed, a sponginess of the area just under the nail bed. And so patients who present with this should be evaluated for possible lung cancer or other serious lung problems. Now let's move on to the workup of a patient with possible lung cancer. Now we've seen some x-rays, and sometimes the first time we suspect a cancer may be because of an x-ray. Now, if you have an abnormal chest x-ray, this is the same one we've seen before where there's a nodule or a mass there. If it's a 20-year-old with a cough, you're not going to think lung cancer because, as we've seen before, that lung cancer occurs mostly in older smokers. You might just think this person has a pneumonia or even tuberculosis or some other process. But if it's an older smoker, your concern for lung cancer should go up. So first thing we do is look for prior films. If this is an old scar that will never go away, every time the person has an x-ray, this will appear. If there are no old films and the person has symptoms of pneumonia, maybe they have a cough, a fever, you might just consider treating them with antibiotics. But if they are an older smoker, you do want to make sure to get follow-up imaging to show that process resolves. If it doesn't resolve, or they just don't have signs of pneumonia, maybe it was they have no signs at all, you should go on to get a chest CT scan. That's the best way to see the detail of this nodule, plus any other problems in the lung. Now, patients may not present with an abnormal chest x-ray. They may actually present with symptoms. For example, if a patient presents with coughing of blood of hemoptysis, that's very concerning in a smoker, that there might be a tumor. And it could be very small. It could just be a very early tumor in airway. So we get a CAT scan, but we also do a bronchoscopy where we look down directly in the airways to make sure there's not a small tumor there that's starting to grow and can be surgically cured. And obviously, sometimes with hemoptysis, as we've shown in a prior example, it can be a very large tumor, but it's something you would want to diagnose and treat urgently. Now, other times we will get a CAT scan will be the first presentation. Now, people get CAT scans for all sorts of reasons, and sometimes you'll find somebody who presents with a scan that looks like this. So this is a CT scan here. I've changed the contrast so all the skin and the bones in here is just too white to really get any detail, and you don't see the difference between the different vessels. You do see the trachea here. But here now you see the lung in detail, and here are lots of little dots here. Those are all blood vessels, and how to determine whether those blood vessels are nodules is essentially a radiology residency. But you see that there's a little nodule out here, and that's really too peripheral to be a blood vessel that size. You know, blood vessels start big and they get smaller as we go to the periphery, and nothing should be that big. The other thing is blood vessels are tubular structures, so if you go up and down on the CT scan, you should see a tubular structure like this. It shouldn't be a nodule that's there and then not there in higher scans. Anyway, what do you do if you find a little nodule in an older smoker? Well, it's too small to biopsy. They'd be like biopsying a needle in a haystack. So one of the first things you do is try to find old CAT scan, because some of these will just be old healed scar. If you find an old scan and it's been there for 2 years without change, that makes it very likely to be a benign process, just an old healed scar. Well, if you don't have prior CT scans, generally what we do is we follow that with several CAT scans spaced over the course of 2 years. And if there's no growth over 2 years, then it's very likely to be benign. If it, however, does start to grow, and we wouldn't get that big, we would just watch for very subtle changes in size, not even that big, but you get the idea. If it grows at all in size, we would consider removing it. Now, there are other times we'll get a CAT scan, and right from the beginning, the nodule will be larger. Generally, the bigger the nodule, especially an older smoker, the more likely this is to be a lung cancer. So again, first thing we do is look for prior CT scans, although we're very concerned about this nodule right here. You can see how big it is. Now, if we find an old CAT scan and it wasn't there a couple years ago, that increases the risk. Or if we found it, perhaps it was only this size a couple years ago and it, for whatever reason, didn't get followed and now bigger, again, we would be very concerned. Now, generally, if it's over a centimeter, we don't follow it with CAT scans serially. Again, because the risk of this being a cancer is much higher. So we tend to try to figure out what this is at the time of presentation. Now, so what can we do? First of all, our first question, is this cancer? One of the tests we can do is something called a PET scan. Now, this is a nuclear medicine scan in which radioactive glucose is injected intravenously. Now, that glucose will go to anywhere in the body that's really metabolically active. And it's going to go to the brain, because our brain is very active. You can see it goes to the heart. The heart is a very metabolically active organ that's pumping all the time. But it also goes to cancers. And you can see when you line up the CAT scan, it lines up exactly where that nodule is. That PET scan results would make this very likely to be a lung cancer. Now, the next thing we can do is we can try to biopsy it. So we can stick a needle across the chest wall. This is something an interventional radiologist would do, and get a sample of the tissue. Now, other times we could do a bronchoscopy, look in the airway, and that's really the decision between a needle biopsy versus a bronchoscopy is really about the location. Is it more in the center? Do we see an airway going to it? We might do bronchoscopy. If it's more peripheral and there's no airway near it, we would go with a needle biopsy. Now, sometimes we don't stop with, do a biopsy. For example, an older smoker with a new nodule, if we've had a whole old CAT scan for comparison, it would be very suggestive lung cancer, and we would perhaps directly assess them for surgery. But there's lots of variations on this theme, and generally, we present any patient like this to a multidisciplinary conference with radiology, pulmonary, oncology, and surgery there to define the best approach for every patient. Anyway, the number one way to cure lung cancer is by surgical resection. So in this patient, now we're convinced with a positive PET scan, this is very likely to be lung cancer. The next question is can we surgically cure it? So one, we would look for distant metastases, and the PET scan is very useful for that. But we'd also have to try to figure out, can this person have lung surgery? Most patients with lung cancer are smokers, and many have advanced lung disease with COPD and emphysema. And so we have to determine whether they have the pulmonary function test reserved to allow them to have some lung resected. When you resect the tumor, unfortunately, some normal lung has to come with it, so that every patient will lose some lung function with surgery. And if we find out that if it can't be resected, because it's metastasized or because the person doesn't have the proper lung function, we would try chemo and or radiation. So in terms of pulmonary function testing, we're saying if a tumor looks localized, can the patient tolerate lung resection? Now, some of this has to do just the geography, where the mass is located. You can say if you have a mass that's very peripheral, surgeons can take a small wedge resection and the person wouldn't lose that much lung. But if the mass is closer to the central airways, you may have to resect a lot more lung. In fact, sometimes an entire lung or pneumonectomy. And there, obviously, you would want to get pre-op PFTs. You want to estimate the amount of lung that you'd need to remove to cure this patient with surgery, and then guesstimate the post-op PFTs, decide whether the patient will have enough remaining lung function to have a good quality of life. So that's the surgical management of lung cancer for early stage lung cancer. Now, we're talking about stages here. Generally, stages, like most cancers, are based on the TMN staging system, where T stands for the size of the tumor. It's better to have a smaller tumor. N stands for the lymph nodes. So with lung cancer, the cancer may first spread to hilar lymph nodes close to the tumor, and then at more advanced stages go to the mediastinal lymph nodes. At more advanced stages may go to the lymph nodes on both sides of the mediastinum. And then it can spread distally with metastases for M. So that's the T and M stage. Now, we won't go into all the different stages of lung cancer, but stage 1 is one that's small, that doesn't have any distant metastases. And stage 4 is a tumor that may be much bigger or involve the pleura or has distant metastases. And you can see there's a significant difference in survival. We would like to find patients with stage 1 that we can surgically cure them, and surgery is the primary modality for that stage. For stage 4, unfortunately, surgery won't work, so we're talking about chemotherapy plus minus radiation. So I'll call that XRT. The stages in between, again, we use our multidisciplinary conference to try to tailor the specific therapy based on what is best for that patient. Now, that's the staging system for non-small cell lung cancer, this T&M stage. So that's squamous cell and adenocarcinoma. For small cell lung cancer, we don't use that. We just determine whether it's local. Here's a cartoon of a chest whether it's local, meaning contained in one chest, or whether it's widespread. In those cases, if it's local, we would use chemo plus XRT, but if it's widespread, we would use chemo alone. Now, how can we improve lung cancer mortality? We talked that only 15% of patients will be alive 5 years after the diagnosis. So how can we do better on that? So one way to do is to stop patients from starting smoking. That would decrease smoking rates, will certainly decrease lung cancers. We've already seen that the decline in smoking has led to a decline in lung cancer rates in men and is just starting to show that same decline in women. The other way to do, what do we do about our current or former smokers? So is there a way that we can find lung cancer earlier? And that goes to the issue, is screening useful for patients? So really, it's how do we find lung cancer here at the surgically curable stage versus here when we're unlikely to cure it? We can treat them with chemo and XRT, but again, that is not likely to cure the patient. Now, so what is a good screening test? When we look at screening tests, we're balancing a lot of things. One, we want the test to be sensitive. We'd like a test that picked up most of the people with lung cancer. We'd also like it to be specific. We don't want a test that makes us follow every little tiny little scar that can happen in the lung or any other sort of non-specific property that patients with lung cancer might have. We have to be mindful of the cost. Remember, if we're talking about applying a screening test to smokers, and 16.8% of adult men smoke and about 14% of adult women smoke in the U.S., if it's very expensive, we would be spending a lot of money just on lung cancer screening. We want the test to be safe. So, for example, screening with blood tests are very safe. It's just the very small risk of a blood draw. But when we're talking about other modalities, especially those that involve radiation, we want to make sure that if we're exposing a large number of people to a test, that the test itself is safe. And we also want to be mindful of the risks. There is some risk. You might have a test that has some risk, but also there are risks of finding a patient who actually does not have lung cancer in whom you suspect. Not this case, but let's say it was that other case where a very tiny little nodule right there. Now, what if now you did a biopsy and that person had a major complication of that biopsy? So now just the screening method put that patient for risk, and the patient may not have even had lung cancer. So they've accepted all the risks and they would have no benefit. So one thing about a screening test is we need to apply it to the right population to get the best results. Now, targeting the right group. Again, we talked about most lung cancer presents in the 60 to 7-year-olds, so we would want to target patients, pick them up perhaps all the way down to 50, and depending on the various recommendations, we would screen up to 74 or up to 80. And again, knowing that smoking is the highest risk factor, we would want to target smokers or former smokers. Now, that means we currently target patients who have smoked more than 30 pack years. So that's 30 years of 1 pack a day or 15 years of 2 packs a day, anything that comes up to 30, greater than or equal to 30 pack years. And either active smokers or those who quit but less than 15 years. Remember, if you quit for 30 or 40 years, your risk of lung cancer goes down significantly. So active smokers or those who have recently smoked. Next, we want to pick the right test. Well, what didn't work? Well, what didn't work was doing sputum cytology, just having smokers cough out sputum into a cup and looking for cancer. Now, why didn't that work? Well, again, we'll go back to the same x-ray of this patient here. This nodule, let's say it is a lung cancer, is very peripheral. So that few little cells that fell off here would have to come up here, work all the way up here, and then land in a cup for that to be detected. But they might be making sputum from here and sputum from here, sputum from here. So all that would get mixed up with a just normal amount of phlegm that everybody makes. So you can see that that was not a very sensitive test. Now, we keep showing this x-ray, so why isn't a plain chest x-ray a good screening mechanism? Well, this nodule is pretty apparent. It's somewhat peripheral. But if that nodule was in here or in here or in here or in here, you just wouldn't see it. So these two things were just not sensitive enough to pick up on lung cancer in smokers, and even the combination of that didn't work. What we do think works is yearly low dose, that means low radiation dose, chest CT scan. Now, low radiation dose doesn't give you the finest pictures. It's not all the detail you might need, for example, with someone with a interstitial lung disease, but it's good enough for picking up nodules. Anyway, if we apply and get yearly low-dose CT scans to the right target audience, we have recently shown it's been associated with a 20% decrease in lung cancer death. And that's because we detect early cancers and we resect early cancers, and because surgical resection is the best way to cure cancer. Now, this does mean that we find a lot of nodules that are not cancer. And those patients have to be followed with serial scans, sometimes more frequently than yearly, until at least we get to 2 years. But again, this is our best mechanism currently for detecting early lung cancer. We think that this cost of this is about $81,000 per quality adjusted life year. So you'll see this term a lot. So it doesn't make sense, particularly, to find a lung cancer, even an early one, in a 95-year-old. It will have a lot of other debilitating medical conditions because their quality of life is not going to improve much by getting surgery for a small little nodule. So in summary, we described the rates for lung cancer and smoking. It's smoking being the number one risk factor for lung cancer in both men and women. We described the clinical presentation of local, which can be asymptomatic, and advanced lung cancer, as well as common paraneoplastic syndromes. We described the role of CT scan, PET scan, and pulmonary function testing in the workup of a patient with lung cancer. And we summarized the effectiveness of screening for lung cancer with low-dose CT scans. And we've also talked about the basic management of lung cancer. And this concludes our module on lung cancer.